Have you ever wondered how cardiorespiratory interactions affect ventilated patients? It's a fascinating field that's essential in healthcare, especially when dealing with patients on ventilation. A key aspect of this is the concept of fluid responsiveness. It is crucial to know when to test for fluid responsiveness, typically in patients with hemodynamic instability and signs of peripheral hypoperfusion. However, it's not required if hypovolemia is clinically obvious, such as in hypovolemic shock or initial septic shock before the start of resuscitation. Indeed, understanding these interactions is crucial for healthcare professionals dealing with ventilated patients. Dive deeper into the concept of how positive pressure ventilation affects stroke volume. Picture this. During positive pressure ventilation, insufflation, or the act of blowing air into a cavity, increases the pressure within the thoracic cavity, or in simpler terms, the chest area. This increase in pressure isn't confined to the chest cavity alone. It gets transmitted to the right atrium, the chamber of the heart that receives deoxygenated blood from the body. When this happens, a fascinating sequence of events unfold. The pressure gradient of venous return, that's the difference in pressure that drives the blood flow back to the heart, decreases. This decrease leads to a reduction in the preload of the right ventricle. Now, what's a preload, you ask? Well, it's the volume of blood in the ventricle at the end of filling, just before it contracts to pump it out. So, if the right ventricle is heavily reliant on this preload to perform its function effectively, or in other words, if it's preload dependent, then its stroke volume decreases. Stroke volume is the amount of blood the heart pumps with each beat. But that's not the end of the journey. The blood doesn't just stay in the right ventricle. After the time required for the transit through the pulmonary circulation, which is the path the blood takes to get oxygenated in the lungs, we reach expiration. This is when the person breathes out. At this moment, the left ventricular preload is lowered, just like the right ventricle. If the left ventricle is also preload dependent, its stroke volume decreases. Therefore, the overall stroke volume of the heart, or the total quantity of blood pumped with each heartbeat, is influenced significantly. As we can see, positive pressure ventilation has a direct impact on the stroke volume. But the story doesn't end here. Let's continue our exploration of the effects of positive pressure ventilation on stroke volume. Now, it's not just the increase in intrathoracic pressure and its impact on the right atrium that we need to consider. There are other hemodynamic phenomena at play during positive pressure inspiration. Think about the pulmonary arterial vessels. When positive pressure is applied during ventilation, these vessels are stretched. This stretching action increases the resistance within these vessels. And what does increased resistance mean? Well, it means that the right ventricular afterload increases. An increase in afterload for the right ventricle contributes further to the decrease in the right ventricular stroke volume. So we see that the effect of positive pressure ventilation on stroke volume is not just a direct result of changes in the intrathoracic pressure, but also involves a complex interplay of other factors. But let's not forget about the left ventricle. The inspiratory increase in intrathoracic pressure also has an impact here. This increase in pressure decreases the transmural pressure of the left ventricle. Now you might be wondering, what is transmural pressure? It's simply the difference in pressure inside and outside a blood vessel or a heart chamber. So as the transmural pressure of the left ventricle decreases, it has a tendency to increase its stroke volume. This might seem counterintuitive, considering we just discussed how the right ventricular stroke volume decreases. But remember, the heart is a complex organ and its dynamics are influenced by a multitude of factors. In conclusion, the effects of positive pressure ventilation on stroke volume are far from straightforward. They involve a series of changes and interactions within the heart and its associated vessels. Each of these changes contributes to the overall impact on stroke volume, leading to its decrease at the end of expiration and increase at the end of inspiration. Thus, all these phenomena concur so that stroke volume decreases at the end of expiration and increases at the end of inspiration. To sum up our discussion on cardiorespiratory interactions in ventilated patients, we've delved into the intricate dance of the heart and lungs during positive pressure ventilation. We've seen how insufflation alters intrathoracic pressure, affecting stroke volume and the complex interplay of preload and afterload. We've also touched on when to test for fluid responsiveness. Remember, understanding these interactions is not just academically interesting, but critically important for patient care. Until next time, stay curious and keep learning.